I know why 40% fail, or a major reason why 40% fail is because right now I have 3 patients with failed back surgeries, 2 with failed lumbar fusion surgery. They had herniated discs, but that was not their problem. That was not where the pain was coming from. Pain was coming from their SI joints. I feel like the medical system is very there's a difference between confidence and arrogance. And like, I'm confident, but I'm humble in terms of like if the moment you believe that you know everything is the moment the insights stop, if you ask me. It can speed up SI joint dysfunction. Most of my students will say the average chronic case will take 4 months. I got it 95% in about 5 to 8 weeks. I can stabilize it. Not 5, the other 5% take, but 95% 5 to 8 weeks, and I can strengthen them without them actually doing anything. Years ago, I had a psychiatrist from the University of California Medical School email me, and he said, "Thank you for your publication of SI joint dysfunction." Hey everybody, what's up? Physical therapist Dr. Ryan Whelton, coming to you from just outside the beautiful Tampa Bay area. The kicker is I develop protocols. So today I am talking about an issue that, so in this clinic where everybody's failed everything type thing, or close to it, I see the same things all day long. So I can tell you what the medical system's missing. They are missing mechanical issues and stress issues. So I see SI joint, sacral torsion, sacral shear, which I've deduced is the most common cause of back pain, and a lot of my students that are doing my SI protocol and sacral protocol, and assessing them the way that my evaluation methods, which I published. They're on my website, wheltonmethods.com. You can get my papers that I wrote on it, and hopefully you are using that and helping people, because I just saw a guy today that can't sleep at night, sleeps 3 hours a night. He's been injected countless times, RFAs, multiple RFAs. He's in the medical field, so he's leery about back surgery because he knows that 40% fail. And I know why 40% fail, or a major reason why 40% fail, is because right now I have 3 patients with failed back surgeries, 2 with failed lumbar fusion surgeries. They had herniated discs, but that was not their problem. That was not where the pain was coming from. The pain was coming from their SI joints. And I know that because I opened them up, just I published in my paper and my rehab results online course, that I show you all my, how to evaluate these things, how to treat them. I go much more in depth in my online course, obviously, but I open these people's SI joints up, rotate their sacrum back, boom, pain's gone. And I'm like, yeah, you didn't need that surgery. But these people get butchered by the medical system. Everybody should be screened from thoracic into the foot for any symptoms that can happen with the nervous system, because they have that, including myopathy. I've seen drop foot that is on my YouTube channel, wheltonmethods.com, or Whelton Methods on my YouTube channel. Go to that and find it. I have 2 cases that I think I labeled it Patients Make Medical History, where I show you someone with foot drop, and I open up their SI joint, and boom, their strength comes right back. And they're usually medical mysteries type thing. So anyways, I see SI joint, sacral torsion, sacral shear. I see what I call stress injuries, neck tension, TMJ, and headaches. Obviously not all TMJ. People can have AVN. They can have, disc issues, but by and large, it's stress injury. I see like plantar fasciitis, which is a mechanical issue. I published a paper on that. It's in my online course, Rehab Results online course as well. Things like that. But one of the main things that shocked me was I kept seeing patients with this intractable, sharp mid-back pain. So thoracic pain. So they would be like, It's killing me right in here, you know? Some of them, it would radiate around. So you would think that's nerve, right? That's the dermatome, right? That's nerve, right? But they get MRIs and they're negative. So they become medical mysteries. And so when I started looking at these patients, some of them had costochondral pain. When I started looking at these patients, I'm like, sharp pain. Sharp pain is mechanical pain usually, okay? But they go to chiropractors, but the chiropractor adjusts their facet joints, or even physical therapists that do it, but they never move over to the rib head and adjust the rib head. So I have like 3 of these patients right now. Fell through the cracks in the medical system. No one knows what's wrong, or it's that bone spur, or it's that slightly bulging disc, the reason why you can't stand up. And it's like, what? You know, like you look at some of these x-rays and MRIs and you're like, that's causing intractable pain. But that's what the medical system does. We look at pictures all day long, right? X-ray, MRI, that's it. That's all it could be, right? But when you do my evaluation methods and you do my protocols, you start to a whole different view of what's happening to these chronic pain patients comes into your reality. And it's stunning. It shocked me when I started figuring this stuff out. And I'm like, oh my God, you know? I'm like, all of these patients, like I've had, 4 or 5 this week, failed everything. Nobody knows what's wrong with them. I know what they have before they even open their mouth because I look at what they tried and how long they had it. And I can tell you, it's usually SI joint, sacral torsion, sacral shear, or thoracic rib misalignments, or, C2 headaches, C2 misalignment headaches from stress, or TMJ, or neck tension, because nobody ever downregulated their nervous system type thing. Or thoracic outlet syndrome. I see that missed all the time too. I did a video on that. Go to my YouTube channel or Spotify. I'm on Spotify now, or Apple Podcasts under Whelton Methods, okay? And click follow, okay, if you want more in-depth teaching on this. So when it comes to thoracic pain, you do not see this on an x-ray and MRI, okay? Which is why these people fall through the cracks. I have a patient right now, and he has low back pain. Nobody can figure out. SI joint, sacral torsion, sacral shear. When I opened up his SI joint and realigned his sacrum, all of his low back pain went away. Then he has this pain right in here, and then he says it wraps around right here. Like, MRI is negative. X-rays are negative. And it's like, how could that be? Now, in my experience, is that these patients go to these doctors and the doctors start referring them to psychiatrists, psychosomatic pain. Years ago, I had a psychiatrist from the University of California Medical School email me, and he said, thank you for your publication of SI joint dysfunction. I was able to fix myself. I've suffered with it for years. He goes, I hear you online talking about mental health and with these patients. And so I started checking my own patients in my clinic, psychiatric clinic. And guess what I found? I'm like, yeah, I know. They're all in there. And I'm like, I know that because my patients come from the most prestigious hospitals in the United States. And they have these mechanical issues. And once they can't figure it out, I've seen them prescribe Haldol, antipsychotics, when they're out of pain in 30 seconds for mechanical issues. I have seen them prescribe countless anxiety patients, anxiety meds, and then depression medication. And they come here, and I just do these evaluation methods, and they're out of pain in 30 seconds. And I'm like, no, this is what's wrong with you. I'm like, I feel like the medical system is very. There's a difference between confidence and arrogance. And like, I'm confident, but I'm humble in terms of like if the moment you believe that you know everything is the moment the insights stop, if you ask me. So like, I have a file cabinet in my mind of people that I couldn't get better over the years that I still think about to this day. And I feel like I should have been able to get them better. And I wait for the chance of being able to see something like that condition again to be able to help, because clearly I missed something, And I know that I'm human and I miss things, right? But when my patients go to these prestigious hospitals, right? Or just generally, but in these, especially the ones that come from the most prestigious hospitals in the United States, and they get prescribed psych meds. And I'm like, how do you go from I can't be wrong? I'm the doctor, I can't be wrong. I can be wrong, I'm pretty good at this job, but I can be wrong, and I have been wrong. I talk about it, and when I was a student, I misdiagnosed this shoulder patient, I was so mad at myself, but I never made that mistake again. I learned from it, right? So I feel like when it comes to the medical system is that we need to be confident but humble, to know that we don't know everything, and the last thing you need to do is start calling people that you can't figure out psychosomatic, Of course there are psychosomatic patients. Of course there are. But not all of them are, and certainly not to the percentage I see in here. It's so crazy, literally, pun intended. Okay, so today we are talking about thoracic rib head misalignments. These people have pain up in their thoracic spine, up in here, okay? They have pain that radiates around to the dermatonal pattern. They can have costochondral pain. I had one patient, I will never forget this woman, and she was older, so you could have written it off to arthritis, right? And she could only stand up 20 minutes in 12 years from this. This is debilitating. This is just like SI joint, sacral torsion shear. It is debilitating. These people are screwed. So if you do not diagnose these people, they go into this medical system and it's checkmate, okay? They inject it, they cut things, you name it, they do it to these people, okay? So this can be completely debilitating. And this woman had severe sharp pain right at the costovertebral junction. And this is how you can do it two ways. You can do rib springing, which I learned at Northeastern University 20 years ago, rib springing. This is not new, right? So what you do is, lay the person on their belly and, stabilize their spinous process and boom, rib spring like that. Now, sometimes they'll stand up and say, yeah, you got it. Like, oh, wow, look at that. Yeah, it's gone. But I find that's not that reliable, There are some people that you just can't get it, like you have to hold it open, just like an SI. You can't just realign it. You have to hold the outflares open and then ask them to do the aggravating motion. So in these patients, what I do is this. This is my diagnostic tool. So they'll complain of pain in here, thoracic rib head misalignments. The chronic ones are completely debilitated, and they have the sharp pain, radiates around, can cause costochondral pain. What I do is this, I say, go ahead and extend back. Usually hurts an extension. I say, go ahead and extend back. So they go ahead and extend back. And they're like, oh yeah, that hurts. And what I do is I take their ribs and I go like this, okay? And what I'm doing is I'm taking the costovertebral junction in the rib head and I'm going like that. And I'm giving it room to breathe. And then I say, arch back while I hold them there. Is it still there? No. Is it coming around the front? No. And that is how you hold it, just like SI when I teach it. When you hold the outflares open, you can get a better assessment. Sometimes it doesn't work with just rib springing, okay? And then that tells you what's wrong with the patient, okay? Now, so if you can take the pain away doing that, or rib springing, but if you can take the pain away doing that, you now have confirmed costovertebral misalignments causing this pain, right? The question is what do you do about it, right? So this is a question. I just had a patient that, in a way, I feel weird talking to patients like this because I generally am a pretty affable guy, right? But this patient I had the other day, I said to them, he's got pain in his back and it's radiating around here, X-ray, MRI, normal. Then I did this to him, boom, pain's gone. Okay, it's a rib head. And I said to them, I need you to think about this question I'm about to ask you because it's beyond important. And I need you to give me the right answer, the answer that you're 100% on. Because this particular person didn't have pain that day. So he couldn't reproduce it by, does it hurt more in flexion or does it hurt more in extension? He couldn't reproduce it, right? So the ones that can, okay, well then if it hurts more in extension and not flexion, then you promote flexion. You don't do extension exercise. You don't do the cow part of cat-cow. You do angry cat, okay? That's it. You don't promote, you don't go into the pain. You're shearing the rib head. But this particular patient did not have pain that day. So I said, I need you to answer this question, and if you need to take some time to think about it, I need you to take some time. But I need it to be an accurate answer because it's going to define what I do, and I can make it worse if you're not sure. And I said, does it make it feel better in flexion like this when it hurts, or extension? And he couldn't come up with an answer. So then I'm not giving any exercises out. If you can't come up to an answer, I can't come up with an answer. I need to see you have that pain before I will give you exercises because I can make this worse. If I go into the aggravating motion, I'm just going to shear his rib head and this guy's going to go into massive pain, right? But he said to me, no, I can't. He kept trying and going like this, right? And then he said to me, when I go like this, it hurts. When I go like that, I can make it hurt. And I'm like, that's thoracic extension. Okay, we're keeping you out of that. So I promote flexion exercises. So in my online rehab results course, I give you the exact sets, reps, that I do. And I also teach them self-realignment of the rib head as part of my protocol. And I generally don't have issues treating this. It's not something I worry about in terms of getting these people better, but you got to get the diagnosis. You've got to get these people's diagnosis correctly, and then you have to tailor your rehab program accordingly, or just use my protocols. So that's it with rib head misalignments. Okay, these people, I'm telling you, in my clinic where most people have failed everything, I see what falls through the cracks, and these people, some of them can't stand up. That sounds crazy. Like, how could a rib head do it? Like, that shocked me too. That they can't stand up, they can't sit for long periods of time without having a knife in their back, but it is what it is, and so people that are doing adjustments all day long, just move over to the rib head and spring that, give them relief. I'm telling you, these people get adjustments all the time, and I'm like, that doesn't help, and they're like, no. And then I move over and I just spring the rib head, like a grade 4 out of 5, just a mobilization. And then boom, they stand up, pain's gone. Or I go like this, pain gone. Special considerations: men, never do this to a woman without a woman present, okay? We live in a very, whatever society. And when I do this to somebody, I always have my assistant there because I'm touching a woman in this area and don't want to be, whatever said type thing. Unfortunately, we have to do stuff like that. But that's something that I make sure that I have a woman present whenever I do something like that. Okay. That's that. And if a lot of people are starting to implement these, obviously all over the world, this is everywhere now, like in 40 countries plus now. So it's pretty awesome. But people are downloading my courses. Everything's online. I put everything online. I have my online rehab results course, which is my orthopedic protocols, sets, reps, everything for each condition. I have my intro shoulder course. That's money back guarantee. Give it a shot. And then I have my online sciatica cervical radiculopathy course, which is, it works for me about 80% of the time. Just stimulate these points and boom, comes right out of their arm or leg. And then I have my VIP inner circle. I'm an inventor, I'm an innovator, and I'm always coming up with new ways of doing things. Rather than revise my courses, I decided to make a group. So for less than a Netflix subscription right now, you can join that group, and I come up with I discuss new outside the box ways of doing things, including a new science I'm working on based on electromagnetism. That is a paradigm shift in the medical field. And then I also, everywhere I went when I used to teach live, someone would come up and ask me, will you teach me how to run that clinic you have in Tampa? And I'm like, no, I'm more of a clinical guy. I'm not really interested in that. And then I started thinking, I got these people that have gave up going to physical therapy. They're not going to physical therapists anymore. They hurt them, And I'm like, you know what? If I could, these people that take my courses, if I could just show them how to market and how to run a business, then wherever you are, you can just target those people. I'll show you how to do it. Get the chronic pain patients in and fix it. You just use my protocols. That's what my students do. They just use my protocols. So anyway, I got a bunch of clinics actually all over the US now that people are doing this. They're bringing people in and fixing them, and they're doing cash-based, and they're not dealing with the nonsense of insurance, because most of the things that we do aren't covered anyways by insurance. A lot of my students are into electromagnetism and that kind of stuff that I am teaching. Like I can speed up SI joint dysfunction. Most of my students will say the average chronic case will take 4 months. I got it 95% in about 5 to 8 weeks. I can stabilize it. Not 5, the other 5% take longer, but 95% 5 to 8 weeks, and I can strengthen them without them actually doing anything. Right there on your mat, you can do an MMT, then you'll muscle test, or the piriformis. You stimulate a different area of the body with electromagnetic field, and their piriformis muscle in a 90-90 test goes from like a 3+ to a 5- out of 5. It's crazy. Anyways, when I figured that out, I thought that was a cool party trick. And then I started to notice all my patients were coming in 2-3 times as fast as anything I've ever seen. And they're like, yeah, no, I'm feeling pretty good. I'm like, really? So I figured out how to speed that up, and I actually teach that in my VIP inner circle. So you can sign up for that on my website. Everything's on my website, wheltonmethods.com. I'm going to be doing a membership coming up. Okay, I'm going to be doing a community. I want to get people engaged, and I want to actually coach. So be a mentor. So people take my courses over the years, but what I want to do is and I'm working on doing it, is to have a space where we can all meet, and like in a Zoom meeting type thing. And if you miss it, you can have access to the library where I'm live, and you can ask me questions, and we can go over this and go over diagnostics, go over treatments, and you'll also have access to a lot of my courses when you sign up for this. So it's going to be really, really cool. And I want to get us all better, including myself, at diagnostics, at treatment, at and then even when patients, you have a patient that you're struggling with, you can bring them in, and we'll work with them. We will evaluate it, and I'll show you how I do it, and I can usually figure it out over Zoom, and it'll be an educational thing. So those of you that are super passionate like me about trying to figure it out for patients, like this is for this group, in my opinion, or it's for the people that want it the most, because the thing that has fascinated me over the years is that although there is very intelligent people in the rehab field, there is this intangible that makes someone great at what they do, and that intangible is curiosity, and the drive to know the answer, and the ability to tolerate unconventional ways of thinking. That right there makes the best therapist. I've traveled this country, I've taught, I've interacted with people, and those people are the best, not the people with the highest IQs that got straight A+ in school. That has nothing to do with anything. Not interested. If someone applied to say, hey, I want to work for you, Ryan, and they were like, I went to the #1 school, whatever it is, PT school, to me, I'm like, so, can you think? Can you solve problems? Can you do things outside the box? Because if you're going to stay in the box, you're going to get in the box results. That is what matters, not your GPA in school or any of that stuff. We sell our kids a load of crap, if you ask me. Although I tell my kids it's important to do well in school so you can get into the college you want to go to. There's academia and real world. Real world is intuition, solving problems. And then there's academia, which is solving book problems, So very different, very, very different. And anybody will tell you that's been in the clinic. Yeah, you can learn all you want in the book, but when you got a real human being in front of you in pain that you can't figure out, like, you can go back to your books all you want, but sometimes it's not in there, and there's no, Venn diagram to tell you how to diagnose it. You have to, maybe it's this, maybe it's that. Why don't I try this? Why don't I try that? Anyways, those make the greatest clinicians that I've found. Okay. Other than that, I will let you know about the community that I want to create. Other than that, peace. Love you all.